Well, thank you. Dankeschön for this introduction. And that sets quite a stage, because I'm not sure whether I will reach that. And I saw all the hands going in the air and thought, well, what will you then do in the future? Just look at the screen what the computer predicts? I don't think so. Honestly, I'm probably more skeptical than the average person in this audience about this. What I do think is that we can learn a lot from models, and that is what I want to focus on today. And thereby, I also really want to thank the organizers for giving me the opportunity to share some of this. And I'm very pleased as an engineer to see that there is so much attention in the program for innovation and what engineers could mean to the field. I'm very, very happy with this. So what is a model? That's an obvious question to ask first. And of course, a model is a simplified representation of something real. In this case, we will talk about the heart and the circulation. And I was thinking, what I learned these days, I learned something about the German interpretation of the RVOT. Because let me ask you this. I'm a Dutch person, so we, of course, have a lot of cliches about German people. You'll have probably more about the Dutch people, I'm quite sure. But I thought, who else in the world can think of the RVOT as being an Autobahn? That can only be the Germans, right? So then that, sorry?
Without speed limit.
Just wait, because that was my next joke. So I will refer to a few things using models and in combination with real data as well. And those are some of the topics that I will touch upon. It's exercise, and obviously that has to do with the speed limit, because the flow goes very fast through the RVOT. And the rest are kind of pathologies, and some of them are pressure overload or constricting problems. And I'm sure that we Dutch people can model that on your Autobahn, because when we go for skiing, we end up with our caravans on the German Autobahn, and we cannot reach your infinite speed limit. So, well, now let's talk a bit more serious, and this is what I want to announce as well. There is, obviously, if we think about the RV in general, this is situated in a very complex position. And you probably have seen similar figures like this in the past, but there are so many things surrounding the RV affecting that structure quite a bit, and it's pump work. I'm not going to name all of them, but what I do want to announce now already is that next month there will come out a spotlight issue on the RV in cardiovascular research. It will be published in a month from now, and it's edited by André Legertch. And some of you may know him. He is a cardiologist specialized on the role of the RV in athletes, and especially in those athletes dying of sudden cardiac death. And one of his quotes, which I've seen already in his introductory chapter of that spotlight issue, is the cardiac output is only as good as the worst ventricle. And I really like that quote. Maybe it's a bit simplified, but it just tells us that you can have a perfect left ventricle. If it's not properly being filled by the LV, then the system fails. And it's really a system. So this is basically the spotlight issue I was talking about, and it will cover many topics of RV function, so genetics, pediatrics, everything. So let's talk about pulmonary hypertension. Well, this movie runs properly there, not on my screen, but so we all know the paradoxical septal motion in a pulmonary hypertension patient. This is an adult patient from the Amsterdam group MRI data, where you can see a very nice leftward septal shift that is quite dynamic. People say, well, the septum is flattened, but I'm more interested in the dynamics of that change in curvature. And the reason why I will try to explain. But to understand the underlying mechanism of this, we can use a model that incorporates the function of the LV, the pulmonary circulation, the systemic circulation, the right heart, and so on. So for that, we need a so-called system model, and that system model should describe the essential components that we need to ask or to answer a certain question. For example, what is the mechanism behind paradoxical septal motion? And you could think, well, that's easy, because the pressure is higher in the RV than normal, so the septum bends towards the LV. Well, that's true to a certain extent, because it explains why the septum is on average rather flat, but it doesn't explain the dynamic late systolic bulging into the LV, which I found interesting for a few years, and I did my PhD on this one. So wait, sorry, I'm going too fast here. So this slide just tells us that the model I'm talking about is not a statistical model, it's not an animal model. No, it's a model where we use mathematical formulations that describe certain physical aspects of the circulation and the heart that we know of, and also some physiological aspects. For example, the Frank-Starling mechanism. That's in our model. If we stretch the myocyte, it increases the amount of force that it generates. Those are essential concepts that need to be in a model if we want to say something about RV failure. So the model that we use and that we built is called the CircAdapt model. It's work of more than 25, 30 years. So that's longer than my career currently lasts. So one of my previous mentors, who is Emeritus Professor Theo Arts, he is actually the founding father of this model, and he's still very involved in the development of this. And I'm very thankful to him for that, for supervising me as well. I'm applying this model to several cardiac pathologies and questions. And in a nutshell, the model is a modular model. That means we represent each artery in the circulation using the same physical and physiological formulations. It's just that the parameters could be slightly different. Arteries have a more thicker wall, muscular wall, than veins. And this is what is described in terms of parameters, but the underlying physics are the same. The same holds for the heart. We have the valves in there. You can see that here. I can use this pointer, I think. Yeah, there are valves in here. There are input impedances of the large vessels, and there are obviously resistances that represent the microcirculation. Also, we have the pericardium in there, which is pretty important if we look at the RV. Because pericardial pressure does affect RV and also modulates interventricular interaction. In this model, we can vary regional parameters in the heart. For example, we can create a left bundle branch block. This is just an example and one of my other hobbies. So that's why it's shown here. But we can also change myocardial stiffness, contractility regionally in the heart. So let's now look at what happens if we use this model to simulate pulmonary hypertension. And I've done that in several ways. Obviously, I increase pulmonary vascular resistance. That is what is happening in PAH patients. The heart will react to that in an acute fashion. And this is what I will show in the next few slides. But also, the heart will remodel. it will hypertrophy in the RV and eventually dilate. But the dilation is probably part of decompensation. So to create several levels of cardiac adaptation, I just approached it in a very engineering way. I said, well, I increase pulmonary vascular resistance so that the mean pulmonary artery pressure at rest is 55 millimeters mercury, which is quite high. And I let the model adapt to a certain pulmonary vascular resistance halfway. And then I stop the adaptation in the model, so the model is allowed to hypertrophy and dilate. But then I stop and I increase the pulmonary vascular resistance a bit more, so that you end up with a situation where the heart is not entirely adapted to that level of pressure overload. I can also do no adaptation, and then I get the most extreme situation of decompensation. So then the heart is not adapted to an increased load at all, but I do increase that load. And I can do the opposite. I can let it adapt fully to that increased pulmonary vascular resistance. So now we end up with 3 virtual patients that have mean pulmonary artery pressures of 55. One is completely adapted, remodeled, one is partially adapted, and one is not adapted at all. This you could see as a kind of decompensation. Well, this is how the hemodynamics look like on the right heart. So on the top here, we see pressures of the right ventricle and the pulmonary artery. On average, this black line is 55 millimeters mercury, but you see that the level of decompensation dramatically influences, for example, the diastolic pressures, which is what you would expect. And you might think now, well, our patients will never reach those levels of diastolic pressures. I think I agree, but I'm not sure. I'm not the expert there. But the model can deliver that. Whether it's really realistic and whether this patient would have died already, I don't know, because the model doesn't complain. So we have flow velocities across the valves. The interesting part here as well is that you see that the morphology of the outflow pattern does change with the level of decompensation. I don't know exactly why that is, because we didn't do an in-depth analysis of that, but it's just interesting to see that the parameters of the ventricle, and here you see the hypertrophy of all the walls, that you see there's really growth of the RV, which is what you expect, but you also see hypertrophy of the septum, which has actually been reported by the Amsterdam group, that in severe pulmonary hypertension patients, you have shrinkage of the LV. And that's simply because it's not loaded enough anymore, and if you don't use it, you lose it. So you have hypertrophy of the RV and shrinkage of the LV. So if we then look at LV hemodynamics, you see nothing changes actually, except that the diastolic pressures on the LV also increase. And this is not due to any change of the tissue on the LV side. This is simply because the septum moves into the left ventricle and actually prevents the LV from proper filling. And this is what increases actually the diastolic pressures on the left side. And this is also why the inflow pattern of the left ventricle does change with pulmonary hypertension. There are many other reasons, of course, but this is the acute effect coming from our model. Also, if we look now at septal motion produced by our model, we see that with decompensation, we get more pronounced, especially late systolic leftward septal motion, as you've seen it in the patient. So now, looking a bit deeper in the tissue function, we see this, and that is that this is strain, so this is shortening and lengthening, ejection and filling. In the completely compensated heart, those strains remain rather homogeneous, uniform. If we decompensate, the RV is loaded much more than the LV and the septal tissue. And that is what you see here. These are signals that you're probably not familiar with, but this is what the model can give you as well. This is strain and stress. So the area of this loop is actually the work done by the tissue. And then you see that in the decompensated case, you really get an extreme work overload, mechanical overload of the RV free wall tissue. And that the LV actually starts to show a very weird figure 8 loop. And that's because of this stretch late during systole. So you see that the contraction of the RV is prolonged, and there where the afterload, where the LV and the septum start to relax again, the RV still contracts. But now it's much easier for the RV tissue to actually stretch the septum and push it into the LV instead of keeping the pulmonary valve open. So you get a very inefficient situation where the tissue still contracts, but it can stretch the neighbors across that start to relax already, because that's simply easier than pushing blood through into the RVOT and over the valve. This is loss of systolic function of the RV. And why is this? This is simply because of, okay, this has been shown as well by the Amsterdam group. You see these patterns in a healthy control and a PAH patient at rest, and you see those patterns look pretty much what our model reproduces. So why is this? And that is the simple property of myocardial tissue, which we all know as being the Frank-Starling mechanism, and that is that if you stretch a myocyte, it produces more force and it prolongs its activation. And especially this last property causes the problems here, because the RV is being stretched a lot more than the LV and the septum, and that's why its relaxation is significantly delayed relative to the relaxation of the septum and the RV free wall. And that's where actually the leftward septal motion at the end of systole comes from. So it's really a marker of imbalance between loading of the RV and the LV. Okay, then I got in touch later on with André Lagertsch, who I already mentioned, and he saw the movies of the PAH patient at rest, and he said, I do have athlete patients. No, they're not maybe patients, but he was researching the septal motion in athletes. He was a competitor in the Ironman, and he convinced some of his competitors, some of his friends, to do an Ironman. And I'm not sure whether you know what an Ironman is, but this is an ultra triathlon. So that's 4 kilometers swimming, I think a whole marathon at the end, and 180 kilometers cycling. So the professionals do it in 8 hours, but it's 8 hours maximum exercise, which is very bad for your heart. And he was investigating this because the incidence of sudden cardiac death when they retire is really high in those people. Then he said, well, you know, we managed to make an MRI at maximum exercise with a treadmill in the MRI in Leuven. They did that. And we see paradoxical septal motion in those athletes. Why is that? Well, that can be a sign of RV failure. But why would an athlete have RV failure? I mean, then you cannot perform that well, I would say. Well, then he asked us, well, what happens if you just push your model to a certain level of exercise, of cardiac output, that happens in those athletes? What happens then to your model? I didn't know that because I never tried. But then I figured out that indeed, if I take the normal circ-adapt simulation and I make the cardiac output 25 liters per minute with a heart rate representative for those athletes, then indeed, I saw this leftward septal motion as well, which was surprising to me. But then we started thinking about this, and you may already guess what is the explanation for this, and that is simply because we don't have a regulatory system in the lungs like we do have it on the systemic side. So the lungs cannot dilate their vessels that much as we can do it in the systemic circulation. And now there is quite some evidence, and here are a handful of papers, showing that pulmonary artery systolic pressure really increases dramatically with increasing cardiac output. And these are healthy people. These are athletes and non-athletes, and they show the same relation on average, albeit that individual differences do exist. So I still think, knowing this, that an intervention of exercise in your patients is an ideal situation to actually uncover the RV reserve function that is present. But I do know that practically it's not an easy thing to do. All right, so this is another evidence of increasing RV afterload during exercise. This is Andre's arm. This is a heart, where this is the RV, and this is the LV, and this is a racehorse. The best large animal model of the athlete. This is a professional racehorse who suddenly died at the track during a race. And you see, that was because of an LV rupture, which actually happens quite often in those animals, apparently. That's what they told me. But look at this RV. It's huge. This means, and that's because this is an ultimate athlete, this racehorse, its RV is trained so well that it can reach levels of exercise that are enormous. So again, this is evidence that the RV is very important during exercise. But how do we simulate this in circ-adapt? Well, we have to assume certain things. To make things simple, we assume that the systemic circulation has a continuous afterload for the LV. So if we increase cardiac output, we assume that mean arterial pressure is pretty well controlled and maintained. I do know that it does increase a little bit, but this increase is marginal relative to what happens on the RV. So for simplicity, we assume constant mean arterial pressure. Then the pulmonary circulation is different. We know that it actually behaves non-linearly, and in this case, this is pulmonary hypertension, but actually the tangent of this line is pulmonary vascular resistance. This is the mean pressure drop across the pulmonary circulation, so mean pulmonary artery pressure minus wedge pressure, or mean pulmonary venous pressure, and this is the flow going through. What we all measure clinically is actually something different. We measure 1 point here because we use mean pulmonary artery pressure divided by cardiac output, and that's PVR in Wood units. This is 1 point, and that assumes linearity going through 0. So that's why we all think that with increasing exercise, PVR decreases. But actually, if we look at the tissue, it's not that true, actually, because from 5 to 20 liters per minute, it's rather linear. And the small decrease in pulmonary vascular resistance that does happen, that is due to distension of the vessels. And the very fast decrease in the beginning, that is due to the recruitment, which we know from the West model of the pulmonary circulation. So then we have to assume a heart rate relation and a stroke volume relation as function of cardiac output, and we just took data from a medical physiology textbook because we didn't have the real data of a healthy human being. So then, if I run these simulations and I look at how mean pulmonary artery pressure behaves as function of cardiac output in our model, it actually behaves very well. And this is a kind of validation. It really is on top of these very recent data, which is, I have to admit, these are non-invasive measurements of mean pulmonary artery pressure, but this is what is measured recently. So I think I'm already taking too much time, isn't it? So I was thinking to end this presentation, what happens if we combine all this and we start to simulate pulmonary stenosis, pulmonary insufficiency, because that's a possibility in our model, and RV myocardial failure, and we run this exercise protocol and see what happens to, for example, central venous pressure, which I guess is an important marker of symptoms. Pulmonary insufficiency we simulate by simply linearly increasing a regurgitant orifice area of the pulmonary valve, and pulmonary stenosis is a linear decrease of the effective orifice area of the same valve. So these, let's assume a critical pressure, and this is central venous pressure. I call it mean systemic venous pressure here. And we can simply assume, well, let's say a patient can handle a mean central venous pressure of 25 millimeters mercury. Beyond that point, it will really show symptoms, and I'm not so sure whether this is very realistic. You can probably tell me, but this is what I assumed. Then, in the normal case, with a competent valve, then we see this behavior. And the reason why it non-linearly increases at very high cardiac outputs is because the RV becomes overloaded relative to the LV. This is what I explained already before. So now let's increase more severe RV failure. So I decreased contractility of the RV myocardium only. And then you see that exercise tolerance, if I may call it like that, is severely reduced because I reach this critical pressure much earlier than I do here. Here I reach 22 liters per minute, and here it's just 17 or something. Then if I induce pulmonary regurgitation just by making it incompetent, and once again, this is an acute intervention to the model. This does not take into account chronic remodeling of the heart. Then I was quite surprised myself to see so little effect. So little effect of leakage of the valve. So then I thought, well, how can we explain this? And then I realized when I plotted pulmonary regurgitant fraction here, that actually with exercise, there is less and less and less time for regurgitation to occur. At very high heart rates, very short cycle times, the diastolic time that is left is very short. So there is little time for the regurgitation to actually develop. And that's what you see here. You see that at baseline with the most severe leakage, you have a regurgitant fraction of 50%, and it really decreases to 50% of that, so 25% about at highest heart rates. With RV failure, obviously, you reach your limit much earlier. So now, what we did is this is a wrong label I see now, because this should say pulmonary stenosis, and it says regurgitant orifice area. That's wrong, sorry for that. But the results are not the wrong ones. And now I see here that the red one is an effective orifice area of 1 square centimeter, so that's a severe stenosis. That dramatically decreases my exercise tolerance, hemodynamic exercise tolerance. I'm not talking about metabolics and respiration. That's not in our model. This was just a kind of sensitivity analysis because I wanted to show you the purpose of a model, and the good thing about it is that you can simulate things in isolation and in combination, and then see how certain outcome parameters depend on this. It certainly does not represent the complexity of the patients that you are treating, because then we would have to vary a lot more things. But this is really helpful in understanding basic hemodynamics. That's the main point I would like to get across. So I want to conclude with that, and that is that computer models can help to interpret this. And referring to the introduction by Titus, I think that it is a great tool, and that the future potential of it is that it can help us to predict treatment effects, but there's still a long way to go for that. And I'm not gonna read all those conclusions, but the last point what I wanna make is to reach that point is a good symbiosis to pediatric cardiologists, clinicians, I should say in general, physiologists, and the computer nerds, scientists. So this is really important. People have to learn each other's language and listen to each other and recognize each other's problems. And this is very crucial to the potential success that can get out of this. So those are the people working on this. In red is my own team. Those are the young PhD students, my postdoc, who is a great guy as well. And those are the people of which I received all the nice pictures of the athletes, and I'm collaborating with them. On the picture here, André Lagertsch, and of course, the funding of the Dutch Heart Foundation is very important. And if you want to download the tool, and we have a very nice educational tool that you can use to educate medical students using simulations, please go to this website and download it for free. Thank you for the attention.